Okay, guys, let's finish up. 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 Huh?
Inside a computer?
Yeah, what was that? Okay, what is it for?
Computer. Because remember when we went to the
Studio? So
yeah.
that one will be better than this?
So it's not that it will be better, it's gonna save us a lot of money.
Okay.
Remember, like, this, when I put all the stuff together, it would cost like $1,200. So now we can like take a rate of
Awesome.
And then I also got RAM, which is memory for it.
Yeah.
They had it on sale a couple of days ago for $30 instead of $70.
What I want to do is, I'm going to try to, by the end of this year, my goal is to be more consistent with students and collect all the people who are back pay and then get a loan from a bank to just like expand quickly, like it will always come. Well, I need to solidify something, like at least there. Here it's okay. In the Caribbean, so I can compete with other schools. We have to be able to compete because at the end of the day, it's not just about business; it's about Islam. For me, it's the name. So yeah, and it's important. Why can't we? We have to beat them. I hope we get like some big donors or something. I don't know. I need to do something. Or at least instead of me getting from bank, if I get it from.
Actually, I'll talk to my sister because where my school was in Long Island, New York.
Yeah.
That neighborhood was very rich.
Okay, all we need is they can lend us, lend it to us, not donate. Lend it to us for us to expand. That'll be a great. We have a year. I want to do it. Let's say the latest by October. So please talk to her. It's very important. No. Phrenic nerve is for the diaphragm. Sympathetic is sympathetic supply. Phrenic is motor, somatic motor, whereas phrenic nerve comes from C4, cervical nerves. Yeah. So mostly 4. Yeah. 4 for life. 4 for life. That's the best. I don't know why I always impose my own views.
It's not related to esophagus?
No. It's related to esophagus in a way it goes across it, in front of the esophagus. See, esophagus is in the posterior mediastinum. Phrenic nerve is in the anterior mediastinum. Phrenic nerve is right here. So it's mostly related to the heart or in pericardium, if anything. This is why when you have chest pain, the same phrenic nerve supplying the pericardium sends it to. Yeah. Okay, good. Are we good? We cool? BBF? Okay. BBF. Best babes forever. Me and Hani, we can handle it.
Okay.
Only Superman can handle these comments, right?
We are in Illinois, so that's allowed.
Is it? You want me to tell you a story? Huh? You know, when I come first, because in Afghanistan we hold hands and we hug. It's lovely, it's beautiful. We don't have anything in our heart. We don't go beyond it. It's friendly. So when I came and I had this Ethiopian friend in ESL class, I'm like, let's go. Because we didn't have a soccer team in Crescent Heights High School. So let's go to the principal to start a soccer team. So I'm holding. As we go in, and then these girls are, you guys look beautiful. I'm like, yes, we are, of course. I didn't get it what they meant. I didn't get it. And then he started laughing. He's like, you don't get it? I'm like, no. He's like, leave me alone. But, okay. Now, there are few areas where the esophagus can be constricted, which can lead to dysphagia. So again, the chief complaint of any esophageal problem should be what? Dysphagia. Dysphagia means difficulty swallowing, not painful, that's odynophagia. Difficulty swallowing. Either you cannot swallow, it's stuck or whatever. The feeling of food being stuck in the esophagus somewhere. In the lower esophagus, Okay, lower esophagus. You could have dysphagia in the lower esophagus. Please go lower esophagus. Go a little bit lower. No? It doesn't want to go lower. Okay, there you go. The lower esophagus, you can have dysphagia if the diaphragm is somehow overdeveloped and it can constrict. So, so the diaphragm, remember the diaphragmatic hiatus? Right? So that's one area. You can also have here something remember that, hypertrophy of the LES. Hypertrophy of the LES. The LES doesn't open. So LES problems can lead to two things. So please remember this, the LES. So if the diaphragm hiatus is too tight, it will lead to dysphagia, correct? So I want to talk about two things. The diaphragmatic hiatus or ring, it could be too tight. It could be tight. Or it could be loose. Okay. So that's, now if it's, the other term that could be used is contracting and relaxed, okay? So if it's too tight, and too tight, it will lead to dysphagia, correct? Okay. What if it's too loose? It can lead to hernia, but GERD is the right one. GERD. Very good. Or acid reflux. Acid reflux. Okay, so that's hiatus hernia. But now, how about if this is the LES? Same thing. LES, if it's too tight, it's known as achalasia. A tight LES is referred to as a disease called achalasia. Achalasia. Okay, and I'll come back to that. But anyways, LES that's too tight, again, it leads to what? Dysphagia. Too loose leads to what? GERD. Now, the entire GI is supplied by parasympathetic nervous system. The contraction of GI is primarily done by who? Parasympathetic nervous system. And parasympathetic nervous system has acetylcholine as a neurotransmitter. Okay? So, if you have increase in not acetyl-CoA, acetylcholine. Okay, acetylcholine. Increase in acetylcholine will lead to what? Increase in peristalsis. Okay, increase in peristalsis. And it can actually, open the valve too. Okay, so look for those things. Now, in achalasia, we discussed achalasia, right? Okay, let's go. So if this is tight, the LES is tight, you will call this achalasia. Achalasia. This is a disease. A disease of tight LES is known as achalasia. A disease of loose LES is known as what? GERD. Very good. Okay, so we're going to focus on those things. But now, I want to tell you anatomically, there are two areas here constricting the esophagus. Lower esophagus is either by the diaphragmatic ring or by LES. So that's one thing. Okay. Again, now, you see this area? This area, arch of aorta can also compress the esophagus. Arch of aorta. Arch of aorta. Arch of aorta is directly in contact with what? Esophagus. What if you have aortic aneurysm? Aneurysm means what? Yeah, a bubble sticking out of there. Okay, so let's do that. Let's make a bubble. When this bubble grows, it can push against the esophagus. Now, aorta is rigid. Trachea is rigid. Trachea has cartilage. It cannot be compressed. Aorta is rigid wall, thick wall, because it has high pressure. Don't you think a vessel, the most important vessel of your body, that has the highest blood pressure, shouldn't have thick walls and rigid walls? It should. That's common sense. So aorta is not compressed, but when aorta enlarges, esophagus always collapses. We talked about this. So don't you think it can compress the esophagus? It does. So aortic aneurysm can give you dysphagia? Of course, of course. But please remember, specifically which aortic aneurysm? Arch of aorta. Arch of aorta, which is usually caused by syphilis or hypertension. Syphilis or hypertension, the cause of that aortic aneurysm. Okay, so that can lead to dysphagia. We haven't even talked about diseases yet. We're just simply focusing on what? Anatomy. Just because aorta is related, the arch of aorta is related to what? To esophagus. Therefore, you can have dysphagia due to aortic aneurysm. Okay. What if the aneurysm is in the thoracic, descending thoracic, here? Again, it can compress. Again, it will compress the esophagus. Okay? Here, it's not common. Most aneurysms are common over here. Yeah. Very good. So that's two areas. Now, you see this left main bronchus? Left main bronchus? You see this one? You see right here, it's connected to what? I mean, it's compressing what? The esophagus. So now, if you have somehow hypertrophy of this, or a disease of the bronchus, or rigidity of the bronchus, it can also compress what? Esophagus, and it can also lead to dysphagia. Okay. So now we're going to go further. You know, in my picture, you don't see the heart, you don't see the lungs, but this area is really tightly packed. There's not much room. Here, you as if there's room between, technically even the aorta is direct contact with the main bronchus. Let me show you. Let's increase the main bronchus. Look. This is how much it should be. There shouldn't be this gap. Everything is tightly packed. Everything is tightly packed. Okay. I draw it so that you can see things. Yeah. Thymoma? Yeah. Thymoma, so it's not in front of the trachea though. So it wouldn't affect the esophagus. Thymus is in front of the trachea. Okay. Yeah. So it's not related to esophagus. So it wouldn't cause dysphagia unless it metastasizes. Unless it metastasizes.
Even if it has like a large tumor.
Now, see, this is an excellent question, but it's about 6 months in advance. So I'll tell you what it is. The most important association of thymoma is with myasthenia gravis. You might not know that. So if you read something, that's what they're talking about. Thymoma is a tumor of the thymus. Thymus is right here in the sternum notch area. Here is the thyroid gland, and here's the thymus. So thymus is the anterior mediastinum in front of, you know, where the carotid bodies and the carotid arteries and jugular veins separate. That's where the thymus is located. So esophagus way behind. There's no relationship between them. But yet, thymoma could be associated with dysphagia. It's not because of the relationship or anatomical relationship. It's because thymoma is most commonly found in myasthenia gravis patient. Myasthenia gravis is a disease of muscular fatigue. So in those cases, so you're talking about completely something else. In those cases, the esophagus gets fatigued and they cannot swallow. So there is dysphagia, but it's not because of thymoma. So if I'm asking about that condition and there's nothing else, you'll associate thymoma because it's related to myasthenia gravis. Yeah. Okay. Now, so one constriction is right here. Okay, one constriction is at the level of diaphragm and LES. Good. The second constriction is at the slightly upper level of arch of aorta. And the third constriction is left main bronchus. Okay, so now what? Who cares? Well, guess what? There's one more constriction, which is usually not natural constriction. These are natural constrictions. 1, 2, 3. 3 natural constrictions. Okay. That means if the bronchus is hypertrophied, calcified, blah, blah, things, an aortic aneurysm or diaphragmatic constriction, they can cause problems. But now, what if you have bronchogenic carcinoma? Lung cancer. The most common lung cancer is bronchogenic carcinoma. Bronchogenic carcinoma, meaning this cancer is mostly related to bronchi. So bronchogenic carcinoma, can it give you dysphagia? Yes, please say yes. And please memorize. Bronchogenic carcinoma, bronchogenic carcinoma. Would it cause dysphagia? Of course it would. The history will be telling you a 55-year-old or 60 or 70 or 80-year-old male or female these days, doesn't matter anymore, smoker. That would be the main clue. And then you will say it's lung cancer. You take chest X-ray, CT scan, you see a mass. Okay? So that's one. For number 2, please remember, lung cancer. Bronchogenic. Lung cancers are of different types. Bronchogenic carcinoma. Bronchogenic carcinoma. You have to memorize that. Bronchogenic carcinoma can give you what? Dysphagia. Okay? So that's one thing. An aortic aneurysm. That's another one. Okay? Okay, what else do we need to do? There you go. Oh, there's... What color can I fit in there? Huh? Green? I just want to draw a thin line so we can see. Okay, good. We went as far as we could. Here you go. Green, come. Now, a vagus nerve comes. It's slightly posterior, okay? A vagus nerve will come. Wow, that's good enough. A vagus nerve comes and it loops around. It gives you a branch. It loops around the arch of aorta and it gives you recurrent laryngeal nerve. This nerve will go to larynx. Larynx is here. Look, larynx is, the voice box is right here. But where is the sternal notch? Over here. And that's where you have the arch of aorta. So the nerve, recurrent laryngeal, why is it called recurrent? It's returning back upward. So esophagus is coming down. But it gives you a branch here. Initially, look, maybe let's think of it this way, so just so you understand. You see aorta. Aorta used to be here. This used to be aorta, or arch of aorta. Initially, aorta started as a single, and it has two arches in the embryogenesis time, during fetal development. So you will have recurrent laryngeal nerve in both cases. So this is the vagus nerve going, and it gives you this nerve that loops around the aorta. Two vagus nerve, left and right. Okay? This is in this area. Good? Because larynx is located here, right? So then, but as we grow and we stretch, our neck stretches, the heart stretches down. So the arch of aorta comes down. When it comes down, it's going to do what? Drag this nerve down with it. So that's why you will see the recurrent laryngeal nerve there, even though it's supplying here. But because the aorta comes down, it's stretched down. Okay? So recurrent laryngeal nerve is related to it. That's the left recurrent laryngeal nerve. The right recurrent laryngeal nerve loops around the right bronchus because there's no arch on the right side. That arch dissolves and during embryogenesis disappears. Okay, so now if you have aneurysm or something like that, you can have dysphagia because of difficulty swallowing, but you will have dysphonia because of recurrent laryngeal nerve being compressed. Dysphonia means difficulty speaking or producing sound, or hoarse sound. Yeah. Okay, so always expect that in this area, in the upper esophagus. So usually upper esophagus problem will give you what? Dysphagia and hoarseness. Okay. Dysphagia, dysphonia, dysphagia, dysphonia. Okay, so that's one thing. Now, the lower esophagus was related directly to what? It's sandwiched between aorta and what? Left atrium. Left atrium. Now, left atrial diseases or left atrial hypertrophy is common. Left atrial hypertrophy is very, very common. Let me write it down for you. Left atrial hypertrophy is very common, actually. Especially if somebody has mitral valve. Now, what is the cause of left atrial hypertrophy? Mitral, write this down. I know we're not in the heart, but it's okay. Mitral valve stenosis. I know we haven't gone to the heart, but it's okay. You're a medical student, you can handle things. So, mitral valve stenosis. When the mitral valve is narrowed, it leads to left atrial hypertrophy. You know, like, you've seen bodybuilders, right? Bodybuilders are what? Hypertrophied people. They have hypertrophy of their muscles. Their muscles are bigger and thicker. So when you say hypertrophy, that's what happens to the heart muscle. So left atrial will become thicker, very thick. When it becomes thick, what happens to the esophagus? It's compressed, it's pushed. So again, you can have dysphagia. So left atrial hypertrophy will give you what? Dysphagia. Look, this is just enough information for you to solve 2 or 3 questions. Let's not worry about the details of it for now because we're not in cardiology. Yeah. That's a different thing. No, they will call it dysphagia because the esophagus is not developed. It's blind pouch. Yeah, it's not because of constriction or compression. Yeah. Yeah. No, you're right though in that sense. Yeah, you're right. You're right. Yeah. A lot of things. Yeah, that's one of them. It can cause it. Very good. Okay, so far, the cause of dysphagia, compressive dysphagia, is lung cancer, left atrial hypertrophy, diaphragmatic constriction, and then left main bronchus can constrict it, aortic aneurysm, and so forth. And of course, tricuspid fistula, we'll talk about it when we go to embryology. Okay. All right. So I want to go until 11:10, and then I'll go over the questions, okay? What time is it? 11? Well, let me go over the questions. So On Friday, I'll start with disease of the esophagus. Okay, just know the function of esophagus is only one thing, and that is passage of food. Now, if the tube is designed to pass food, not absorb, not secrete, why would they want to have columnar epithelium? Doesn't make sense. So it has to be squamous epithelium because it doesn't need to absorb or secrete a lot of things, correct? Small, flat cells. But multiple layers, because with the way we eat food, it can cause erosion, so it should have multiple layers. Okay? So know 3 layers of the esophagus: serosa, mucosa, muscularis. No muscularis in different level. In the proximal 1/3 is skeletal, and then the middle 1/3 is mixed, and the bottom 1/3 is smooth. Smooth is autonomous control. It's not under your control. It's under the control of sympathetic parasympathetic system. And then skeletal is under your voluntary control, somatic control. Okay, so know those things. Epithelium you should know. The layers you should know. Circular layer and longitudinal layer, you should know that. It's the circular and longitudinal muscle layers of the esophagus that causes peristalsis. Peristalsis is a propulsive movement, like a wave-like movement. Okay? That's nice. So peristalsis wave will be like this. Think about it this way. So if this is esophagus, let's see if I can do something about it. What is it?
It's doing the wave in a stadium.
Yeah. Exactly, like a wave in a stadium. Oh. No, I didn't want to do that. So let's do this. So esophagus is generally collapsed, correct? I just want to show you how should, a peristaltic wave look like. I'm going to try my best. Focus on the red, and that's the food bolus. Yeah, that should work. Okay. So esophagus is generally collapsed, right? It should be a collapsed tube. Okay. So let's see if this makes sense. So this will be the wave. So it keeps opening and closing behind the bolus. So think of it that way. Okay, so it's always collapsed. It's a soft tissue. So a lot of things can compress it. Yeah.
What if the esophagus is dilated?
Now, it will dilate if there's obstruction. Food will accumulate. Otherwise, it would not be dilated.
No, like myotony, muscle weakness, something.
Yeah, it's not dilated necessarily. It's just it doesn't have the peristalsis properly. Maybe like in scleroderma. Yeah. Okay. All right. So please, these are the diseases you should study them for Friday. Achalasia. Wow. Achalasia. GERD. Okay. Plummer-Vinson disease, and then we have Boerhaave, Mallory, Weiss tear, esophageal varices. What else do we have? Diffuse esophageal spasm. Now all of this is in your book, so just know all the esophageal disease. How about that? Let's make it easier. Okay, review, just read them once. Don't worry about the symptoms, okay? Whenever you look at the book, Open one page. Let me show you something. Open one page to the esophagus. Page 13 of GI. What is on page 13? Achalages. Look, all I want you to study for Friday is when it says UNC and UNP. That's all. UNC and UNP. Is that a lot for each disease? UNC and UNP. Underlying cause and underlying pathology. So when you open the book, for each disease, that's all I care for now. Can you do that, guys, for Friday? So Friday I'll have a quiz. I'll have a quiz. First 10 minutes on these. Okay? It'll be one-line questions, for example. All the disease in that esophageal section. But it will be only under underlying cause, underlying pathology, UNC and UNP. Make sure you know them, okay? All right. Huh?